Okay, so here's our next section on voltage. Our ability to sense the voltage from the heart tells us a lot about the thickness of heart walls. It tells us about the shape of the heart walls and the relationship between the heart and the chest cavity. Here's an outline of our section on voltage. First, we'll go over disorders of increased voltage. We will look at left ventricular hypertrophy, right ventricular hypertrophy, left ventricular aneurysms, and hypertrophic obstructive cardiomyopathy. Next, we'll look at disorders contributing to reduced ventricular voltage, such as amyloidosis and cardiac tamponade. Left ventricular hypertrophy is caused when there is thickening of the left ventricular wall. LVH is usually caused by ventricular remodeling from long-standing hypertension, but it can also occur from aortic stenosis, hypertrophic cardiomyopathy, or in athletes. LV hypertrophy is measured by the echocardiogram and also by the ECG. On the ECG, there are a ton of different criteria that can be used to suggest LV hypertrophy, but it's really not that efficient to apply them all in each situation. I found that by looking at 2 criteria, that this should be enough in most situations. The first screen for LV hypertrophy is the Cornell criteria. In this screen, we look at lead AVL and at the height of the R wave in AVL. And then we look at the depth of the S wave in lead V3. If we add these 2 values together and the R plus the S wave are greater than 24 millimeters in a male or greater than 20 millimeters in a female, then this is suggestive of LV hypertrophy. Now the other criterion is the Sokolov-Lyon index. This one is a bit more complicated because now we're looking at leads AVL, V1, and leads V5 and V6. So first, calculate the depth of the S wave in lead V1 and add this to the taller of the R waves in either V5 or V6. If the S in V1 plus the R in either V5 or V6 is greater than 35 millimeters in either males or females, then this is suggestive of LVH. Also, if you look at the R wave in lead AVL, if the R wave is greater than 11 millimeters, this is suggestive of LV hypertrophy. So this is the Sokolov-Lyon index for left ventricular hypertrophy. Next up is right ventricular hypertrophy, or RV hypertrophy. RV hypertrophy is a bit trickier because we primarily look at the height of the R wave in lead V1. Here you can see that the R wave is much taller than the depth of the S wave in lead V1. You can also see that the R wave is greater than 7 millimeters in lead V1. And the height of the R wave is so large that it spills over into leads V2 and V3 as well. These are all indicators that the patient has RV hypertrophy, especially in the absence of other factors that could increase the height of the R wave in V1, such as Wolff-Parkinson-White or dextrocardia, for example. Now here's a really interesting ECG. We see that the patient has sinus rhythm, left axis deviation, and really noticeable ST segment and T wave elevation in leads V1 through V5. And also you can see really deep Q waves in the same leads. If you were to see this without knowing anything about the patient, of course your first impression is that this is an anterior ST segment elevation myocardial infarction, or STEMI. But what if I told you the patient did indeed have an MI 1 month ago, but since then has had no further ECG changes and is not currently having an MI? In this case, we would be worried about an aneurysm of the LV, and that this structural change in the heart has caused permanent electrical changes on the ECG. LV aneurysm can sometimes be very dangerous because the patient can have structural failure of the aneurysmal wall, leading to tamponade and sudden cardiac death. This happened several days after myocardial infarction. Here's another interesting ECG that you're likely to see perhaps in younger patients. What we see here is a sinus bradycardia with a really unusual T-wave inversion pattern that's really noticeable in both leads 1 and 2, and also in the precordial leads V2 through V5. You can see that in the septal leads V2 and V3, there's a sharp, strange, dagger-like Q wave and a deep and symmetric inverted T wave. This is the classic appearance of hypertrophic cardiomyopathy, which is usually caused by a genetic disorder affecting the cardiac muscle at the sarcomere level. So let's change gears for a second and look at low voltage ECGs. Here's an example of a low voltage ECG from amyloidosis. You can see that the limb leads are only about 5 millimeters in amplitude, and the precordial leads are less than 10 millimeters in amplitude. The interesting thing is that if you were to take an echo of the heart, you would actually find thickened LV walls. So the combination of thickening of the heart but a low voltage ECG makes an infiltrative disease, such as amyloidosis, the most likely disease here. And here's another example of a low voltage ECG, but this time the cause is different. Instead of diseased thickened ventricles like we saw in amyloidosis, this time we have fluid around the heart that is causing a hydraulic compression of the heart and which is blunting the electrical voltage signal, contributing to this low voltage ECG. Now look what happens when we insert a needle, called a pericardiocentesis, and we pull off a few liters of fluid. Look how the voltage is now increased in the limb leads. Now the limb leads have a voltage greater than 5 millimeters and greater than 10 millimeters in the precordial leads. Now that the fluid is not electrically insulating the heart's voltage, we get a much better view of what's actually going on as the voltage normalizes.